welcome. My name is Dr. Sarah Cole. I'm an orthopaedic surgeon based in Cairns, and tonight we're learning about pain. Apparently, I don't know enough about pain, as we learned in the last instalment. And I just want to acknowledge the country on which we're meeting. Meetings that are considered significant are requested to have a recognition of country. And I think that this tonight is a significant meeting. So acknowledge the elders past, present and emerging. So David, would you two like to introduce yourselves as well?
Yep, so I'm David, exercise physiologist, owner of Dall'Alba Co. And I love talking about pain, and I've been in pain a lot. I love causing injuries, and I have a lived experience. Yes, not to my patients. And I have a lived experience of pain, which is kind of what led me down the path of working with people in pain. The Explain Pain book and multiple Lauren Mosley YouTube videos was kind of what helped me recover. So that was why I wanted to get into pain.
And yeah, so I'm Jordan Bonner. I'm again a senior physiotherapist at Thriving Lives Co. Yeah, so I've only just moved to Cairns in the last 10 months, but yeah, I've worked in persistent pain in the private space, particularly for sort of the last 4 and a bit years or so. I guess my story is less so of being in pain myself, but I guess I was in a prior life working primarily in a I guess like a musculoskeletal clinic in like the acute care setting. And I guess I was just seeing so many clients that were, due to their multitude of factors moving into the persistent space. So I thought something going on here, which led me down a further education and very much, now entrenched in persistent pain.
So we're going to have a format. We've got PowerPoint presentations, but the idea is, as some of you may know, is please interrupt. We love interruptions. Most people try and reserve their questions until afterwards, but please, if you can ask questions as we go, it makes it much more interesting for the people online. And Kerry, you can try and raise a hand, but if you wave, that might help me as well, just because I can see you're a little tiny dot on our screen. So please feel free to contribute.
No problem.
Yeah, and as Dr. Cole said, super informal. So if any of you have any questions, because we have content we could talk about, but we're mindful that it may be things you already know and that type of thing. So does anyone have any questions burning about pain already?
I just want to hear about these nerve fibers.
Well, I actually didn't put them in, but that's fine. So I suppose I'll start from the foundations, right? Well, first of all, the history of pain, and then I'll talk about the fibers.
Yeah.
So I guess pain has started as, like philosophical, like sort of as far back as the 428 BC. People have talked about the concept of pain primarily, I guess, to begin with, it being more of like a unilateral like emotion, I guess, rather than what we now know as being, as I said before, like a multitude of factors. I guess as you can see on the screen there, over the years, there's been so many different theories, I guess, from, I guess, as far as, let's say, a pattern theory of that interpretation of a stimulus, which I guess, then the brain deciphers and there's a pattern of recognition and eliciting a pain response, I guess, through to, semi-recently, like the gate control, where I guess, a gate opens, you interpret a stimulus. If the gate is closed, you do not. Through to, I guess, most recently being more of that biopsychosocial model, which differentiates, I guess, a lot from prior thought, where you can have either physical or psychological pain, but exclusively. Whereas, I guess, most recently we're talking about, as I said, the biopsychosocial, to suggest that, biomedical, psychological, and like your social factors can very much influence the pain that you experience. So yeah, I guess
Yeah.
that's a brief snapshot.
Yeah, and so that's kind of that biomedical view where there's something wrong with the tissues
Mm.
and there's something that's causing damage, and that damage is sending a pain message up to the brain, and that's kind of, and they feel pain.
Mm.
And that's kind of going back to Descartes' kind of concept of, you know, you touch fire, it sends that pain message up.
Mm.
Whereas when we talk about the fibers, it's this notion of a nociceptor. So it's a receptor that detects noxious stimuli, so something that's potentially dangerous. So we've got 3 different kind of receptors throughout our body that pick up on danger, pick up on either temperature changes, mechanical changes like push, compression, that type of thing, and chemicals, so pH changes, poisons, toxins, that type of thing, oxygen levels and that type. So if we get a stimuli that's beyond what's normal for our tissues, that's when a nociceptor is sent, and that's that kind of danger message. It then goes through the dorsal horn of the spinal cord, and it's kind of like a post office. The post office is kind of like, is this worth sending it up to the brain, or do we need a reflex to kind of help us out here? Does it need kind of higher order thinking and kind of cognitive factors? And if so, and it's based on, like, you know, the excitation thresholds back in physiology. If there's enough, crosses that threshold, sends a message, same concept. So it's an electrical impulse at the tissues, gets turned into a nociceptor or a mechanothermo or chemo message. Once it gets to the dorsal horn, it's all chemical. So it releases kind of neurotransmitters into the synapse. It's kind of like a lock and key. If there's enough, they bind, sends a message up. That's kind of where opioids and medication come in. They can interrupt that kind of chemical interaction. So if it kind of gets that excitation threshold in the spinal cord, it goes up to the brain. That's when it kind of gets really groovy, because there's so many factors at play that the brain can kind of, and that's where Engel was kind of like, there's more to this in the BPS model, in that people can, psychological social factors can have a big influence. So in terms of where we're at now, and our contemporary understanding is that, I suppose, keep it interactive. Can I get a show of hands if pain is an input? Lift your hand up.
To the brain?
To the brain, yeah. No, or if it's output from the brain. Yeah, perfect. And so that's been a really big shift in the last kind of 5 to 10 years through kind of pain science. And the current definition was only updated like 3 years ago. An unpleasant sensory and emotional experience associated with actual or potential tissue damage. So there was this notion that pain means there's damage. Now it's pain means there's some perception of threat, because pain is a protective system. And there's so many protective systems that we have: the immune system, the motor system to get us to get away, so many different ones. And the nervous system in the brain, in all its wisdom, will go, pain's the one we need right now in certain contexts. And that's where contextual factors come into play as well. We can touch on that a little bit later as well. But in a nutshell, it's an output, it's an alarm system to your conscious awareness that, hey, something might damage you soon, so change your behavior and stop it, get away from it. It's complex. So when they did the definition, they went, we can't fit all this into some snappy line. So there's some accompanying notes, which we won't go through today, but I'd recommend reviewing them as well. They're good to familiarize yourself with. So I love this illusion. So can I get a show of hands if these lozenges look like they're the same color?
Same color?
Yeah.
Are they lozenges?
Yeah.
Put your hand up if you think it's a lozenge.
And hand up if you think they look different. Now keep it up if they still look different. Really? I'm joking. So keep it up if it still looks different. On the right.
Oh.
I'm pretty groovy with PowerPoint.
Oh.
Yeah. So why this happens is pain's very complicated, just like vision, right? So it's a perception based on information that we get from the environment. In this context, it's kind of light and the meaning we make of light. So when we look at the shadow, that tells us that there's a light source coming from the top. When we see the different shading, the laser light's not working. So when we see the different shading, that tells us, that the lozenges are like this, you know, and that's what our brain kind of goes, well, there's two different things there, so they must be different colors. So these kind of, when we cover this thing up and it kind of shows the truth, that the meaning and the context of the lighting and the shadows, that's kind of the things that are messing with people's persistent pain. It's kind of the things that are influencing the perception threat that make the reality not quite apparent, if that makes sense. So there's some awesome experiments on all of this, which we probably don't have time to chat about today, but I'd recommend looking at Lorimer Mosley's videos. He chats about all of these through his presentations as well. And the relevance of it all is it's contextual because there's all those biological, psychological, and social factors at play, which is why we can't just focus on what's going on in the tissues. We can't, like what Jordan said, we can't just focus on, well, they're sad, that's why they're in pain. There's never just one, it's always contributing together. And there's this concern that there's this shift too far to the BPS to the point where you disregard biological, which is not the intention at all. And there's generally a driver biomechanically that may be influenced by things like central sensitization, peripheral sensitization, that's modulated by those psychological and social factors. So examples, biological, actual tissue damage, some type of pathology or disease that's contributing to nociception, or some other damage going on. Whereas in psychological, it's what do you think is going on? Do you think that your bones are made of dust and they're about to fall apart?
Yeah.
All of that stuff. And we've kind of touched on that before, like bone on bone and cookie crumbling, unstable, all of that stuff. And there's so much research on the language influence on pain, which is fascinating. Samantha Bunsley is someone I'd recommend to follow her work. So she looks at how it actually influences pain. And it's pretty impressive. And so what people tell us is kind of social, even if someone goes, oh, I wouldn't lift that fridge like that. If you have the capacity to do it and you weren't concerned, them saying, well, I wouldn't lift it like that, that then becomes some information that can suggest you're in threat. And that can then influence the amount of pain that you get. So the relevance of all of this is, as health professionals, we need to be really mindful of the information we're conveying to them and how is it influencing the perception of threat. And it can be conscious or subconscious. So we don't know what we don't know, and patients don't know what they don't know. So a big part of our role as health professionals is kind of untangling what are the things that both of us don't know that's contributing to that pain. And it's within the kind of BPS factors that could be at play, not just the physical assessment and then what tissue is driving this, because it's never just tissue. Even in acute pain, there's it can be modulated by psychosocial factors. So, the stories of someone gets their leg bitten off by a shark and they have no pain. Right. So what
is like even like, have you heard of the nail story?
Yeah.
I was going to ask if people still say that.
Yeah, it comes up all the time. So there was this bloke that had a nail go through his boot and he presented to ED with like crippling pain. Couldn't be resolved with any medication whatsoever. They did imaging and the nail was going through the toes, as in between the toes. Yeah, so no tissue damage whatsoever, but overwhelming amounts of pain. And if we kind of break it down, he sees it and the information he has is that's through my toe. I need help. And the way to get help is to get pain. And with the shark attack kind of thing, it's that contextual factors. If you get your leg bitten off by a shark, the equivalent tissue damage, if you were in a workshop and someone chopped your leg off, how much pain would you be in? A lot. You'd be like fetal position on the ground.
Yeah.
How helpful is that in the ocean?
Very hard.
Yeah.
Position.
I don't know for you guys, but I sink like a rock. And so in that point in time, the brain and the nervous system is coming up with what is the most helpful thing. And in that instance, it's probably the motor system. We're going to be losing blood, but that's fine because we're going to drown before we bleed out. Right. And there's also the shark. It's a little bit of a concern as well. You can live without a leg. You can't live if the shark's got your head. So the brain doesn't give you pain if pain's not going to help. And in that instance, pain's going to just cause you to sink like a rock. As soon as you get on the boat, what's the most dangerous thing at that point in time?
Drop their blood pressure.
Yeah, and just bleeding out, and that's where pain may then come in, or then go into shock. But that's how context can influence it. And I was telling a patient this story once, and And he's like, oh, stop you right there. I know exactly what you're talking about. And he told me that he was working in the bush and he chopped his finger off. And he said he felt no pain at all. And he kind of put it down to, I'm a tough, hardworking man. I don't feel pain. So it was pretty humble of him to tell this story. And so he drives like 45 minutes to get to the emergency room. And he reckons he's walking up the steps and he locks eyes with the receptionist and just passes out. And he's like, I've never understood why that happens. And he's now like, well, triage, if you walk in and you're like, oh, yeah, I'm right, should be right, see you in a few hours, like you're not going to get seen. If you suddenly drop on the steps, you're going to get your finger looked at. And his nervous system and brain's going, this guy's stubborn, he's hard working, he's not going to just volunteer the information that he needs care. So we're going to take matters into our own hands and see you later, blood pressure. And that's an example of where, and it wasn't necessarily pain in that instance that he had. His brain and nervous system went, we need a different protective system. Yeah, I've digressed a bit. And that's because there's so many complex factors. That's where it sometimes becomes beyond the scope of just the EP, just a physio, just an orthopod, and that's where you need professionals that can kind of come in from every approach. There is an awesome new kind of approach that we briefly spoke about last time through Peter O'Sullivan and that kind of group over at, I think, Curtin, where they're kind of using psychologically informed therapy with CBT and ACT embedded within physical therapy. And that's somewhat the approach that we utilize as well, because you don't necessarily, so a psychologist is really helpful, but there's so many elements to unhelpful beliefs that we as physical health professionals are much more well equipped to deal with. An example may be the classic patient that will come in and they look like they've got a Harrington rod at their back, and they're kind of like this. And we have the confidence to say, hey, you can actually do this and your back's not going to fall apart. And for us to help them through that, sometimes it's giving them education, but more often than not, it's more about experiential learning. It's about giving them that kind of understanding that it is safe and that they're in a safe place. Let's do it and see what happens. And then afterwards they go, oh, I can do it. And so that in essence is an element of CBT as well, and exposure therapy that as physical health professionals, it was in the wheelhouse of psychologists, but it's what we now are learning to embed within our care. And also like incorporating that kind of contemporary pain science in our treatments. There was this big problem of pain splaining where, and I did it when I first learned about pain. It's like, I've learned so much and I can't wait to tell you everything I know. And it just doesn't work. You need to work out what's going on with them, what their individual beliefs are and what they're terrified of, and then target whatever your treatment is, whether it's education, movement that shows them they're safe, that's for them. And that's kind of, but then when there's other factors at play, like trauma and so many other psychological factors, really helpful to get a psychologist involved. But best practice is they're still better at relaxation strategies and CBT in different areas as well. So, and then OTs coming in to change the environment and give them tools and aids and pacing and all that other stuff. So it's really about that. Multi-D approach is the second level gold standard. Top level is IDT. So you're all in the same place. You've got someone kind of collaborating you all, so you're not having to tell your story 15 times to the 15 different professionals. And so the IDT model is what we're kind of trying to create at TLC, so that we can not have to talk to 17 different people that are all on different wavelengths and that type of thing. So yeah, just in a nutshell, it's all about working with everybody, and it's not just health professionals, it's family members. The amount of patients that I've worked with, and you do the Kieran O'Sullivan test and you go, how would you explain this to your family when they get home? They do it perfectly, but it didn't work very well, because then the patient's partner is like, why did you say their pain's in their head? So it's, we learn as health professionals, we don't even learn how to teach. And that's something that I've had to learn in my role. And so it's hard for us to be able to convey it to someone that then they can convey it to someone else. So it's best to just have the patient's partners and whoever is a really influential person in their life actually come in to the consult, so that there's not these mixed messages when they go home. And if that family member has a question, they can ask it then and there. That's the best approach. And then making sure that all stakeholders, rehab consultants, orthopods, physios, psychs, everyone's all on the same page, because there's nothing worse than having conflicting messages. This EP is saying I can't bend my back, this physio is saying I can. You know, so just collaboration as well is really in communication in pain management. So in terms of working out, well, when do we even need to use BPS? Always. You know, acute pain, we still need to work out, well, what other factors are at play here? Because we want to prevent the transition to chronic pain. And we know that if there's all of these underlying factors at play, then it can lead to chronic pain. When we know that it's getting more of a problem is kind of when it's persisting beyond the normal length of healing time, when they're not responding to treatment as they usually would. If there's yellow flags present, which we'll be screening for through our questionnaires and just their presentation as well, and the history taking. And is their pain kind of correlated with mechanical or kind of physiological factors, or is it correlated more with their mood or their sleep or their diet or other factors at play, things we need to consider? And so I don't know if you guys can see that, but it's a nice little graph that just shows that so pain gets this bad rap, you know, everyone's like, pain sucks, but we need pain, because pain, it serves as a protector. It's always been seen as this, well, there's something wrong because I've got pain. Pain is kind of helpful in the acute stage, because if you break your foot, you can't walk on it. And if you do, you'll probably do some damage. So in that acute phase, really helpful. But when it persists beyond that normal length of healing time, that's when we need to knock it on the head and start to treat it. It becomes unhelpful and overly protective through factors in the brain and spinal cord that kind of, I liken it to like, you know, the intensity knob or a volume dial. It's kind of just turns it up. So, you know, the bushfire things, or it's like low risk, medium risk. It's kind of like it's on that red, high risk all the time. And so you're just overly sensitive. So everything hurts more than it should. And so if you don't have a good understanding of what's safe and what's not safe, it's logical for patients to feel like they've done damage, and that amount of pain is a reflection of the damage that they've done. So it's about helping them to understand why this pain is occurring and what's contributing to it as well. I'm mindful I've been talking for a while. Does anyone have any questions?
But it's interesting when you see, you know, that when you touch them and they feel intense pain, or, you know, the sheets touch their leg and they go, and then you can explain to them that, you know, that's not dangerous, and you know, so it's easier when the person is in pain and you can use their little scenarios to teach them about their pain. It makes sense.
And that touches perfectly on its sense making for them. So that's what our education is all around. So when someone comes into us, it's well, how do you make sense of your pain? That's exactly what I ask them. And that's when they'll say whatever beliefs that they've been fed by the internet, by their health professionals, by anything. And it may be, well, you guys probably have some examples. What are some common causes of pain that you hear about?
The injuries that they had like 20 years ago that they feel is still contributing to their pain is a very common.
I felt for horsemen.
Yeah. Gymnastics and, you know, hurt my back like 15 years ago, so it must be that. Yeah.
And so that it always comes up. And what doesn't help is imaging. So that kind of comes into this. So we all know that imaging has a very poor relationship with pain, right? But the big impact of it is being able to convey that to patients. And like when we look at these pictures, what's missing from the pictures? Everything. Exactly. And that's often what they look up, or that's when they search disc bulge, that's what comes up, you know, and it's about showing them, well, and this is even missing a lot too, you know, but at least it's showing them, well, hang on a minute, there's other factors at play there, you know, because telling them that, oh, other people have that and they don't have pain, that's not enough. It's about helping them make sense of, well, how and why, you know, and it's a sensitive thing and you can't just come into it straight away, but it's a really important thing. And all health professionals and GPs are in the front line as well in terms of being able to clearly convey how concerned they are about the imaging. Because the concern the health professional conveys is then naturally going to be passed on to the patient. And there's research that shows that can be conveyed subconsciously as well. So there was a there was a study where they were observing them and only the third party didn't know about what was going on. And the third party was not able to detect which people knew that they were experiencing damage and who did it. So whatever it is isn't visual in behavioral kind of body language and that type of thing. So lots of factors at play, and it brings in our language as well. So what it actually tells us is there's age-related changes. And this doesn't discount from the 2% of pathology that is sinister, or there's often a lot of pathology that actually is driving the pain as well. And so we just got to work out, and that's where we look at the mechanical relationships and that type of thing as well. So this was a really interesting qualitative paper where they had a look at the meaning patients actually make of pain and the language around it. So chronic, couple of steps in a wheelchair, instability, liable to pop, not a lot you can do, wear and tear, something's rotting away, and degeneration, whole person spine. So this stuff comes up all the time in imaging and the things that they talk about. And it's like if someone said to me with a lot of authority that I believe them, your spine is unstable. If I didn't get pain to stop me doing things, there's something wrong with me. Because if my spine's unstable and I still go kayaking anyway, I'm potentially going to settle my spinal cord, right? But your spine just isn't unstable. But if they've got that cognition and that concern, it's so logical for the nervous system to go, well, don't you dare get in that kayak. And the only way to stop some people is pain is the helpful protective kind of output there. And it's really important as a health professional if we aren't actually confident. Like, as an example, if our supervisor says, oh, it's fine, you can do it, but you're not sure about it, that's conveyed to them. So if you aren't sure and you're trying to show confidence, research shows that it doesn't work. They'll pick up. You can't fake it. So they'll pick up on your concern. And that will subconsciously influence the threat that they have.
But I sometimes use the imaging to exclude things, but you know, like you want to do an X-ray, we're talking about this, you want to do an X-ray to maybe exclude a tumor. But then once that comes back as normal, I have to then navigate the disappointment that it's normal. And say, we did this test, we've proven that there is, you know, that you can trust your shoulder or your back or whatever it is, it's all fine. You know, go and use it and go and strengthen it and go and rehabilitate it. But it's harder to explain that than to explain, oh, look at this pathology. It's harder to explain normal and say that normal. The reason why we did this is to demonstrate that it's normal.
Yeah.
You know?
And
I was going to jump in for but I think like taking that opportunity, like to actually, you know, I guess convey that message, like how fantastic is that? There's nothing like I guess biomechanically, like not wrong, but there's nothing to biomechanically wholeheartedly explain why you are experiencing that pain. That's fantastic.
Yeah,
I think it's exactly that. How like that is such a sign to kick on, stay the course, as you said, be active, address the other lifestyle factors or whatever it is that could potentially be contributing, rather than being, I guess, fixated on the idea that my joint, my ligament, my something or other is a soul.
Have the conversation about how to address the social factors, because I see people who are under extreme stress, you know, stress with their family, stress with their job. You know, and I can see that they come in with this enormous pressure on them when they come in, and then we have a conversation and I say, well, it's normal. And then I haven't solved for all the other problems.
Most often where I've seen it's just as much, I guess, about that process of identification of, you know, like the glass smashing moment of, oh my God, until you've like actually asked me the question, I hadn't thought about it.
Yeah.
I even saw it the other day, a gentleman with, you know, persistent shoulder pain that was going really, really well, objectively through the roof, strength, range of motion. Most recently, an acute flare up. And when we were getting down to the nitty gritty, and I'll admit we talked for 45 minutes, outside of, again, the objective assessments, when we got down to the nitty gritty of it, sleeping poorly, leading into retirement, stressing potentially around what am I going to do?
Transition.
So again, it's, I guess, in that space, it's discussing, asking, you know, from our knowledge of all of the varying factors that could potentially be contributing to a painful aggravation, whereas objectively your shoulder's going amazing. What else can we potentially be considering here? Can we, and what can we, can't we change? Because naturally, you know, if you still need to work to some degree to get money, you go, oh, just stop working, you'll be fine.
Yeah.
So it's, I guess, addressing what we can and assisting to guide through, I guess, what we can't necessarily change in that moment.
Even just by acknowledging,
Yeah,
you know,
I think
what
so.
have you been doing? And then they list it all and you go, oh, that must be very hard for you to cope with. And then I'm like, yes, you know, and they're just, when they're talking about themselves, they're listening to themselves. And then sometimes they go, well, maybe, you know, I should change or something. You can't tell them to change. But
No, they have to.
yeah, by getting that conversation going, often they'll come up with the answer themselves.
That's exactly right. I think it's not even necessarily in the moment. It's the conversation you have that stimulates that going away and thinking about it.
Yeah.
When they come back next time, you know, I went away and I thought about it, and you're right, like I forgot to tell you, I have also been doing this, I have also been doing that. So it makes sense because I'm so wound up, all at the same time. But yeah, no
I'm
one.
worried that that's intrusive, you know, worried that.
Yeah. We intrude all the time.
Be used to it.
Question, but then if you so sometimes the timeline, even I do want to know when you fell off the horse, because what did your parents say to you and blah 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 blah.
Yes, yes.
Because it's all part of what's in
Of the story.
That's the timeline of what's building the training.
And we can kind of speak to that, like we normalize it. We go, we know that when people have more things going on in their life, it can kind of turn up our pain system. So is it okay if I ask you some questions about that? Like if you want to get permission. And then
So when you say turn up the pain system, that sounds like a layman's term. So what you're trying to say is that when people have other things on, is it like a cortisol problem, or is it like a neurological brain problem?
There's cortisol, but there's also factors within the brain that can just it influences the amount of descending inhibitory control. So basically it can kind of turn it up and down at the spinal cord in terms of the amount of receptors you have available for nociception and that type of thing. But cortisol is a big factor at play. And then having that conversation with them about, look, we now know that structurally you don't need a surgery. There isn't necessarily an exercise that will fix this. There isn't a manipulation that will fix this, which is really exciting because we know that there's so many other things that it may be. Can we try and work that out? And that's where it opens up that conversation. And a lot of what we do is talking and getting a really extended history, which is why we have extended consults too, because you need to build rapport with someone before you start asking them about these things for starters. And then building that relationship and trust. And generally it's going to be different to what they've had before. If they, expectations, if someone comes in and you start doing exactly what's happened before and it didn't work, they're kind of like, well, what's going on here? I know you're going to give me this exercise and this exercise and this exercise. And a lot of the time there is no exercise that will fix it. It's working out what's the right movement for them that's going to violate their expectations and beliefs to give them the confidence and self-efficacy to do the things that they love. And we can't work that unless we know how they make sense of their pain and all the other factors in their life. And when they are able to, like Jordan said, reflect upon it and recognize these factors, their main priority had been finding the problem. And we channel that energy and enthusiasm into, we've worked out some things that we know will make it worse. So why don't we focus on them? And then we may find that it's going to get better anyway. And they don't need to be looking for the structural driver anymore because we know that it's been ruled out. And that's
there, but
we're going to work with it.
And if it's there, is it the pathology that's driving the pain, or could they have pain that's magnified with it? Like they could have that pathology and it's driving it due to psychosocial factors. And when we address all of those, that pathology is still
What
there.
about the kickback when they say, you're just telling me it's all in my head and you don't care about my pain?
Well, that's like what Helen mentioned. Oh, sorry, Jordan.
I actually like steer into the skid a little bit. It
Yeah.
is.
Yeah,
Like,
right.
it
Yes,
is.
yes.
Every pain that you experience, whether you stub your toe or
Sure.
you've lost your leg, is experienced in your brain. It's though then the caveat of
Yeah.
I'm not saying you're imagining it, but what I am saying is that that interpretation of the stimulus is what you're experiencing.
Right.
Yeah, and I think that I guess to go like back a step, I guess like to the context of everyone's lived experience is naturally different.
Mm.
You know, a mechanic will say, well, hang on, I've got osteoarthritis, just go and take it out and pain won't be there. So, well, actually, you know, yeah, when pain is inconsistent, does that mean that the osteoarthritis is no longer there?
Mm.
Well, it's still there. It's just that for whatever mitigating factor, you're not at that point in time, you're not experiencing the pain.
Mhm.
So I guess, yeah, it's you know, to go back to the conversation about language, it's then just how comfortable and confident you are in being able to interpret,
Take that on.
take on board what the client is actually saying,
Mm.
like picking up on those triggers like of you know the language that they are using to be able to actually convey it back to them in a way, preferably using their own language, to try and yeah, I guess steer them in the right direction.
Mhm, mhm. Makes sense.
And they did,
Yep.
oh, yeah.
Someone else wants to-
Yeah, I suppose if you, this may be asking for a bit of a tip, but I always find it very difficult to navigate patients who's, you know, one of the things that you can identify, one of the things contributing to their pain is something that for you sounds like they can't change. Okay, like, you know, mate, I've been a mechanic for 40 years, like my hands are stuffed, mate. I've got another 20 years before retirement. You know, what can I do? You know, you just fix me, you know, like, well, you can't tell them to retire, you can't tell them to change careers. Like, how do you navigate? Or you know, oh, my sister's, you know, really sick at the moment. I'm in and out of hospital all the time, and going up the stairs kills me, and I can't get up the elevator because it's out of commission for the next 3 weeks. What am I going to do? Don't visit. You know, you can't say don't visit. Like, how do you? What do you address? I guess, in the things that appear as if that you just can't change them.
Yeah,
You
well,
know?
if it absolutely can't be changed, there's not really anything you can do. However, is it changeable, or do they perceive it to not be changeable? And then it's kind of working out what their goals are and what are they willing to do to make a change.
So, for example, for the mechanic, would you go as far as saying, well, I mean, do you undo every nut with your hand, or do you use tools? You know, what tools do you? Like, is that the line you do go?
Yeah, so it's about working out what stimulus is too much and then scaling it back to, and if they're really concerned about the whole, well, this is my livelihood, this is, I identify with this, it's, well, we sometimes need to take a step back to be able to get you to go forwards, and being able to scale it back to the point where you're not booming and busting, and then you can slowly build your tolerance and adapt to it in a sustainable way. And that's where I talk to them about boom and bust. You guys familiar with the boom and bust? Yeah. And helping them to recognize that they may need to make some changes, because it's possible that they won't get better unless they.
I think it's a little bit like what Helen says, the idea is already in their head. You know, if you start saying to a mechanic, you've got a lot of pain in that wrist and you're 40 and you know, you want to keep going for 20 years, what's your plan? You know, what are we doing here? Oh, well, I've got a young guy who's coming through, or my son's coming through, and I'm, you know, going to drop back to supervising, or the books have been a mess for the last 10 years. I don't know where all the money is, you know, like, you know, all that sort of stuff. I think
That's it.
ideas formulated.
You know, like I
Sorry?
had somebody the other day, the mechanic over here, and you know, we've talked about that. You know, I'm trying to avoid doing that. I had to do that, and it was a flare up. But you go, you know, you have an apprentice at your work. Well, no, and this is something that's actually very prevalent. And you're going, you know, in the long term, can we get more apprentices to do those things, because they're used to. Now we're just, you know, nobody wants to train young people, and then they just keep their 50-year-old doing really strenuous work. So, you know, it might actually be a whole cultural change that we need.
Yeah.
And maybe they're the people who can drive it. You know, can you get me somebody, if I'm a really valuable worker, you know, can you get me someone to do that overhead stuff?
Yeah.
And like, and it depends on the barriers as well, I suppose. But like, connecting with their values. If they don't want to because it's what I do, all of that stuff. It's like, well, is that image of yourself more important than these other things you really value, like spending time with your kids or whatever it is? Because we're at a crossroads. We can keep doing what we're doing and it's not working, but you can maintain that perception and image that you have, and that's okay if that's what you want. I probably can't help, but you can keep doing that. Or we need to make a change. And these are the things that I'd recommend. And just, motivation interviewing as well, like what Alan was talking about, getting them to reflect what's important to them and then go, oh, interesting. So you said this, and it's their words, and they go, oh yeah. So, and that's the hardest part of our job, realistically. It's not picking which exercise to give them.
And there's something that I've learned from the women's health is that maybe they're not ready at this point in time. So
Even though they come to see you.
Yes, because they don't know what's involved with getting better. So, it could be that you've got to go away and do this, and they go, well, I can't do that at this point in time. Now, if it's persistent pain, it's been there for ages, maybe you can't do something now, but you might set it in motion then, okay, so I'm going to get holidays in blah, 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 and then I'm going to get fit on my holidays, and then, or I'm going to change, you might just start something up that may take, the process of getting over persistent pain is going to take years anyway.
So why do you have to change it in the first consult?
Yeah, so don't think that, and it could be a planning. Or how would we think you could plan? Like when they stop smoking, they don't, like what's that first one when they just do? I'm going to think about, or I'm going to
Contemplation, yeah.
Well, you've told me what's happening and what could be happening, and we've discussed what might help. I'll go away and think about it, and at some point in time in the future, something might be able to happen. So that way we don't feel so bad.
Yeah.
We look after ourselves as well. Like we can't solve everyone's problems.
I think it's important to drip feed information to people.
So pain-related fear is one of the biggest drivers of everything. And I'm sure you've all heard of the fear avoidance model. Yeah. So we're scared, we get unhelpful information from whoever, adds to our rumination, our catastrophization. We do nothing, disuse, disability, depression, and it's just we're more likely to get re-injured. So that's where we come in to be able to go, well, hang on, you've had an injury. Let's not give you that unhelpful information. Let's steer you down the right path where you can kind of on the road to recovery. And there's a really good graphic by the Noy group in Explain Pain that's in a little bit later. But we touched on this before. It's kind of like what happens if they stop moving and they stay away from pain because they're terrified of it. All that happens is they get deconditioned. So we're always changing, like neuroplasticity, they like the term bioplasticity to give the notion that it can change outside of our brain in terms of like our receptors are changing every 3 days, so if we can influence the perception of threat going in, we can influence how sensitive our nervous system is. So we're always changing. So if we do little and less, we're changing, but we're getting more deconditioned. So we need to redirect our energy to changing in a way that's going to let us adapt but not flare up, which is kind of, you get those patients where they get that aha moment, oh, I'm not damaging myself, it's just pain and I can handle pain. And then they go out and they do way too much, they flare up, they boom bust, and you're like, well, hang on, mate. I love your enthusiasm, but the nervous system it's still kind of like, hang on, this is too much. You're stressing us too much. We can't recover and we can't even adapt that fast. Like you got to scale it back. Like if you haven't walked for 4 years, you're not going to just walk the amount you did in your day. Your tissues can't tolerate it. It's too much. So the same thing happens when you've been in pain and you've been deconditioned for a long time. You can't just do that much, even though you know that it's not damaging you, if that makes sense. Not to mention the inflammatory cascade that goes on, because if pain isn't stopping someone pushing through, and that's a protective mechanism, and the nervous system is well aware that this is beyond the normal tolerance, it needs another protection system, and that might be the immune system. Well, pain's not stopping you, John, so have some of
Yeah, get sick.
Yeah,
Yeah.
have some of this,
Mm.
get sick, get some inflammation, something that will get them to stop stressing their body too much. So this is that graphic from Noy. Can you guys read it? Probably not. So it's essentially, I really like to go through it with some patients to help them. It helps them kind of go, oh, that all makes sense, what I've been through. So they get to a crossroads where there's an injury, there's a fork in the road, they go down anxiety town, there's a balance between helpful and unhelpful information, and that's where we have a big part to play. And this is where it really influences whether or not they're going to have chronic pain. And whether or not they're catastrophizing, then they get the freak out corner. So I'll come back to that a bit later. Then cortisol corner, like you mentioned.
Yeah.
And then see a mental health professional. So every professional that they see that can't help contributes to that kind of, there's something really wrong with me because all of these amazing professionals couldn't fix me, So we need to be really careful with how we work with them in terms of if we go too hard too fast, then we're just another person that contributes to that. And so the fearville, so they're terrified, they avoid everything, and then disuse, depression, disability. The compo railway, we all know how complicated that is with litigation, and one person saying there's nothing wrong with you, and the other person saying you shouldn't be walking, put your neck brace on for your ankle injury. Like it's a nightmare. And then so this bit up here is the opportunity bypass. So this is where pacing, kind of like what we were speaking about, like what's something that doesn't flare you up, and knowledge. So they'll no pain, no gain. It's KNOW. If you know pain and you know what's safe, and if you can have pain that's tolerable and you're not causing flare-ups, well, go gangbusters, But that's where we as health professionals are kind of like a coach, like a guide. And
they're looking triggered.
and so basically that we're not giving them the exact exercise they need to fix it, or the exact manipulation or whatever. It's they pretty much have everything they need. Generally, it's about giving them the knowledge to do what they need to do. And that's when they get onto the comprehension highway, because they've made sense of their pain and they understand. And then they can get to the bravery chicane, because
The what?
bravery chicane.
Okay.
So because it's terrifying and pain sucks, it hurts. And when someone says do it and you're like, it hurts, but I know it's safe, it still hurts. So you got to be pretty brave and also be vulnerable, like with the things that you have to disclose, like, oh yeah, I'm not going well in my relationship, or all of these different things that you got to be really brave to recover, because you've got to talk about beyond just your tissues. And when they walk in to see an EP or a physio, that's not necessarily their expectations. So it's really important for us as health professionals, like what you were talking about before, is to give them some insights into why we may explore things that seem well out of our wheelhouse, but are becoming more and more relevant and within our scope of practice. It's a lot of like this research that says physios, and that's just because there's no research on EPs. They'd say the same thing, that physios don't feel equipped to deal with things like that, and purely just changing beliefs, which is crazy because it's so important.
Was it a subject at university?
No. I mean, when I was at uni, chronic pain was one slide and it said complex, not well understood, next slide. And that was it. It was really tragic. So this is kind of graded exposure. So I touched on it before. It's kind of doing a little bit so the body can adapt. So protect by pain line is that point where your nervous system's saying, hey, if you keep going, you will do some damage. It's really hard to damage ourselves when we have control, right? Because pain will get us to stop. When we cross that tissue tolerance is when we didn't really have control. Say something hits us, like in a car accident or something like that. If it just happens too fast for us to get away from it, or if it's so low level that it's not even firing our nociceptors and it causes that damage over time as well. Or if we're distracted, we're meaningfully engaged in something so much that we're not even concerned, or if that's not the most helpful protective mechanism at that point in time, if that makes sense. So this is a really good graph because it's helpful to help them understand that they're actually way safer than everyone with a normal protective system of pain. because theirs is wound right up. They're way less likely to damage themselves because theirs is going to start ringing the alarm bells way before they can even damage themselves. So it's giving them that freedom to be like, well, yeah, if you can tolerate the pain, you're not going to damage yourself. And then finding movements that are meaningful to them, that's going to get them there. But then with that caveat of don't go too hard, because we know what happens in terms of boom bust, that kind of graph. And so there's this new protect by pain line, and it's way lower, as you can see, but the buffer's a lot bigger. And that buffer can be due to inflammation and psychosocial factors and central sensitization and that type of thing. And then we've got the baseline. So that's the point where you're in pain, but you're not flaring it up. So it's a tolerable amount that you can go to bed, wake up the next morning, and it's not bad. Yeah. And then you got the flare up line, and that's where it's no good. That's the no-go zone. And then we got the new tissue tolerance line. It's lower because naturally you've had an injury, you're deconditioned, but you've just got to do a bit above the baseline. You'll go into the flare up line eventually. It's got to happen. It's helpful when it happens in a period of care, because if you discharge them and then they have a flare up, it feels like the world's ending because they feel like they've gone straight back to square one.
That's the work.
Yeah.
Yeah.
Yeah. And so to be able to navigate that, and I like to have a conversation with them and prepare them for, you will get a flare up at some point. You know that, you know, it's not linear, it's like this all over the place. That's what happens. And them being able to have the flare up, rationalize, could I have done any damage there? Probably not. It's so much more comforting for them to know that they haven't just herniated their disc or ground their discs to dust or something, whatever language they presented with initially that we've gone through. So the main thing is discussing that buffer as evidence for them that they can do more. And the size of the protection buffer is to do with psychosocial factors as well. Yeah. So how do we reduce the sensitivity? We know that pain is driven purely by the perception of threat. So anything that influences threat or perceived threat is what we need to target. And so a clinical tool through NOI is like a protectometer. Have you guys heard of that before?
Yeah, sorry.
Protectometer. So it's like SIMS and DIM. SIM is like, it's just nice little fun acronyms to make it easy. So safety in me. So a safety in me in terms of things I see might be Jordan smiling face at 18, right? Whereas I might be a dim for him, which is danger in me. Yeah. So it's things that you see, hear, smell, think, believe, people in your life. So these are all things that you can kind of, once the patient's aware of all of these factors, you can talk about it. If they come in and they're sure that it's a bone wrong in their foot, and you go, well, what do you think? What beliefs? They'll just switch off and think that you're saying that pain's in their head. So this isn't something you go to within 2 minutes in the consult, but it's a nice tool to give them as homework and go, well, now you can appreciate how many factors are at play. Go home and work out, maybe when you eat apple pie, you feel good and your pain isn't as noticeable and things like that. And that's a sensation as well. So things you feel. So this is it here. So you can buy it as an actual thing, but you can also just create a table. And then, things you hear, see, smell, taste, touch, things you do, things you say, things you think and believe, places you go, people in your life, and things happening in your body. So it's just a little scaffold for them to be able to do some things on their own without you. Or you can do it in a consult as well. So like what you mentioned before, like the whole pain is real. They did this pain revolution, which I'll talk a little bit more about it later.
You've got
5 minutes. All right. So in a nutshell, they went, let's find out what's important to people in pain. So they had people that lived experience of pain, like 1,600 people, qualitative research to find out what, when they recovered and stayed recovered, what was meaningful for them to learn. And pain is real is number one. So they often felt invalidated. It happens less now because we've learned a lot in the last 10 years. This is over 10 years of research. So they worked out these 9 key pain facts, which is all online with great resources. And then the marketing team said, you've got to whittle it down to 4. They're not going to read 9. So then they whittled it down to 4, and it's these ones. So pain protects us and it promotes healing. So it's not a bad thing. Acutely, it's great, but it becomes overprotective, particularly in persistent pain. many factors influence it, and there are many ways to reduce pain and gradually recover. They're the 4 things that we're like, all right, if you're going to learn anything, guys, learn this. So I'd recommend looking them up if you want some guidance. So the Pain Revolution, has anyone heard of it before? So it's like so it's a not-for-profit organisation that is all about increasing the awareness of pain and high quality pain care and upskilling health professionals in pain education. Does anyone have any questions before I start this little spiel? No? Free reign. So it's coming to Cairns. They do 3 different things. Rural outreach tour. So they get on bikes and they cycle from town to town and they teach health professionals and they teach the public about pain. They offer 2 different workshops because, as you can imagine, it's tailored a little bit differently. And then the other thing they do is they like a charity for how much they can run, ride or swim, I think, to just raise money and awareness, and then the local pain educator program. So they upskill local health professionals through 2 years of training with UniSA Pain Cert and just like internal training with Pain Rep to equip them to then teach other health professionals in their region about pain, so that they're creating these, they're called local pain collectives. So networks of people that all are across contemporary pain science and high quality pain care. So the relevance of all of this is they're coming to Far Queensland in September. And that's the map where they're riding. And Cairns, it's on September 7th. If you want to book a ticket, there's a QR code. So this map, the other relevance to this. Oh yeah, so this is the LPE program, what I was talking about before. And I'm on a ride. So I've never cycled before. I was almost morally opposed to cycling. It just seemed like so much time to stay in one position and the risk of getting hit by a car. Like, I'm a scaredy cat. So
have you been hit yet?
No, but I first ride came off on train tracks, so I learned my lesson.
Yeah.
Jump on me. Funny hole. So I'm going to be one of the local pain educators. Bonnie Bryan's a psychologist in Cairns, so she'll be a psychologist for LPE. There's one up in the Tablelands, Penny McKay, and Jay Whittam, a physio in, I think he's at Mission Beach. So we're going to have a few little collectives. If anyone's interested in joining a collective, reach out to me, because we're going to be taking names soon to start this network. And we just kind of meet on like a monthly basis for about 5 months. And then as a group, we deliver a pain education workshop. And I promise I'll talk less. Like everyone else talks. Because it's all about empowering everyone to talk more. So I will make a conscious effort.
You said it.
And so shameless plug is, so I'm fundraising for the Pain Rev, and the money goes towards upskilling LPEs to be in the LPEP program and that type of thing. So if anyone is interested in supporting a good cause, I promise I won't show you any more photos of Lycra, unless you follow our Facebook page, because that's probably covered. And if you're interested in more information, so Explain Pain book is a really good place to start. David Butler, Laura Mosley, and then Explain Pain Supercharge, if you don't mind a bit of more sciencey stuff. But Explain Pain is a good place to start. And then for patients, I feel these 2 are really good. Greg Lamar, he's a chiro, changed to a physio over in Canada. It's quite a good book. And then another shameless plug, this book I was a co-author with Essa. It's like an ebook. It's just to kind of give people some guidance around how to move more despite persistent pain as well. So they're more patient resources. I can't imagine as much you'd learn from the Essa book. It's more targeted for the layperson. Yeah.
Beautiful. Very good.
Any questions? Nailed that.
The curable app.
Oh, yes. Yeah.
So, as a therapist, you can, go online and you can, give your client 6 weeks free, subscription to the curable app. So the curable app has got all this stuff, in bite-sized pieces. There's one that's, words can harm. There's, some mindfulness, there's making a list of gyms, you know, so it can, if someone started it at 6 weeks and had enough time to work through it, their life would be changed by the end of it. So if they don't have much money, then, you know, you're giving them something, and then they have the talks that they have are free. It's a little podcast, and so you can get them in. What did I say? Mind, body. Anyway.
Well, thank you. I'll
Yeah.
stop
So you can, once you go in and have a look at it, then it's powerful. It's if you can't see somebody or you can't afford to see somebody, you've got and it's artificial intelligence. So, you know, talk to you nice and non-judgmental. You know, you've done it today. Would you like to do some more? Or, you know, yeah. So it's definitely worthwhile.
No, click back on that. If you've got it.
Curable.
Yeah, click back on.
Yeah.
Just for a second, because you actually probably want to stop that. Stop screen share.
Oh.
Yeah, that's all right. That's all right.
Any other questions,
No,
guys?
I'll wind it up online because, and just double check there's I can't see any hands being, very good. Hands being waved. Hey.
So I just want to say, I think there is great value in taking people through all of this stuff. I've been doing this for a long time now as well. And I think that some people feel really confronted by the information on that's written out there on, say, Curable on the app. And they really need the time to do this slowly and one-on-one. So it's often a drip feeding process, and we need to pace them very, very steadily. So Sarah, I can see that, you know, you and the doctors are in a really difficult situation, but the thing that you can do is reassure them that this is the diagnosis or this isn't the diagnosis, and what you need is assistance to work through this. And so then referring on to the allied health so that they can take them through that process, and that we're going to help them get better. So, yeah.
Thank you.
Yeah,
thank you,
you.
gentlemen. Thank you, Kerry. Thank you, gentlemen. Thank you,
Thanks for
everyone,
listening.
for coming. I'll hit.